So now we're on Learning Plan 6, Manage Care for Patients Experiencing Disorders of Childhood. So Chapter 11 in Varkarolis is Childhood and Neurodevelopmental Disorders. So just as an introduction, about 20% of the children and adolescents in the United States suffer from a major mental illness that causes significant impairment. And usually that impairment is seen at home, at school, with peers, and also in the community. So that's a horrifying statistic, 20%. And think about the kids and adolescents that are not in treatment because of varying reasons. Perhaps their family doesn't want to get them to treatment. They don't have insurance. And we're going to talk about barriers in a minute. But it's very possible that that number is even higher because of the kids that are kind of flying under the radar and possibly not even getting help. So basically, it is when you have kids that have major mental illnesses, it is a big disruption to their normal pattern of childhood development. And if they're not developing normal as children and adolescents, they're going to have a great deal of difficulty functioning as an adult. So let's think about some of the barriers to assessing, diagnosing, and treating younger people. So first of all, one of the first barriers will be that younger children they're more difficult to diagnose than older children just because of their limited language skills and their cognitive and emotional development. So it's always going to be harder to correctly and accurately diagnose a baby, a toddler, a preschool age. The younger the child, the more difficult it's going to be to give them an accurate diagnosis. Children also change just way more rapidly than adults do. That early childhood period up to about age 5 is a time of very, very rapid brain growth and development. So because of that rapid growth and development, lots of times parents and even caregivers just kind of wait and see whether the symptoms kind of go away by themselves. Maybe they think it's just something that's developmental and they'll grow out of it. It'll kind of get better on its own. Or maybe it could be like they just think it's an initial response to perhaps some trauma that's eventually just going to get better by itself. But sometimes that wait and see approach means that the child is not getting the early intervention that they really need that could actually help them with that disorder so that they will, become able to grow and develop normally into adulthood. So some other barriers might be lack of consensus for screening children, lack of coordination among multiple systems, lack of community-based resources and long waiting lists for services, lack of mental health providers, and cost and inadequate reimbursement. So all of those things can really keep kids out of treatment. So just thinking about the lack of mental health care practitioners, especially there is a lack for sure in the area of childhood and adolescence. There really aren't as many in this area. I'm just thinking about like Sheboygan and I think even Manitowoc. We don't really have a wealth of people that have backgrounds in child and adolescent mental health. I don't know if they've hired one yet in the Aurora system, but the one child and adolescent psychiatrist that we had retired a few months ago. And so far, the child and adolescent, well, it's actually an adolescent unit on 1K, has been closed now for several months. And how difficult that makes it for families that need their adolescent to be hospitalized for reasons of depression, psychosis, behavior problems, all different types of issues. And now, if those adolescents need hospitalization, they're going to have to be going to a larger city. So Milwaukee or Green Bay, some other area that can provide those services. And so think about how now, because we don't have anybody in this local area, how we're probably making it even more difficult for people to get care because now there's so many people that are kind of being funneled to another city and they probably are already overwhelmed themselves. So yeah, that's a real need. We really do need more practitioners that are working in this area. So the last bullet point, lack of services, I kind of already talked about that, and premature termination of treatment. So some families just stop treatment really before the child is or adolescent is ready for a variety of different reasons. Sometimes if they are going to another city, perhaps it's just really difficult to manage all the kids in the family and all the extracurricular activities and school and everything and jobs to get that child to treatment on a consistent basis. And so many times services are just stopped pretty quickly and not continued, which would, of course, would be more helpful for that child. So that's definitely a problem that is seen in this area. So, just to kind of a quick overview of characteristics of a mentally healthy child or adolescent. So, that would be a child or adolescent who trusts others, sees the world as safe and supportive, correctly interprets reality so they don't have any psychotic symptoms. They have developmentally appropriate behavior. So, if you have a 3-year-old or a 2-year-old, it is absolutely developmentally appropriate for that child to maybe to have a temper tantrum. Um, the terrible twos and saying no and all that can be kind of difficult. Those are tough stages at 2, 3-year-old. However, that's developmentally appropriate. And if you see a 10-year-old doing those same behaviors, well, that's not developmentally appropriate. So we're also thinking about a child that doesn't violate social norms, that really their behavior is socially appropriate. They're not biting and hitting other kids and taking things away, stealing, them as the child gets older, especially. We can think of a variety of different types of behaviors that would be against social norms. The child has a positive, realistic self concept. So, positive self concept doesn't necessarily mean that they think they are the best person in the whole world, because that's not realistic. So, to have that balance of being positive and yet realistic. So it's funny because I was just talking to a little girl today, a friend of mine's granddaughter, and the friend was kind of telling me that this little girl wasn't very athletic. And so she piped in with that she dances and that she used to play soccer, but that she didn't really enjoy it that much. So I kind of said, well, yeah, that's athletic to be a dancer, to take ballet. That's very athletic. So I was kind of trying to counter kind of what, Grandma had said, because she was kind of pointing out that this little girl's brother was very athletic and very into sports, and that she felt that this little girl was not very athletic. Maybe she kind of said it thinking the little girl didn't hear, but she did. So anyway, but I thought she had a nice comeback. So nice realistic self-concept. Maybe she wasn't that good at soccer, but she was good at ballet. So that's the type of thing we're looking for. We're looking for the child to cope with stress and anxiety at, again, an age-appropriate behavior. So again, if a 3-year-old starts, maybe, or a 2-year-old starts sucking their thumb when they're anxious, well, okay, maybe you're hoping that's something they'll grow out of, but again, more age appropriate. But if you have, again, a 10 or 11-year-old sucking their thumb when they get anxious, that is not age appropriate. So then the next bullet point is that they're mastering developmental tasks and new situations. And of course, certainly we see a lot of examples of this in just the way kids grow through their school years. So they're learning different things. They're learning, and you could even think about a younger child, a toddler or preschooler, as they're learning more and more things to do with self-care. They're learning more to feed themselves, to dress themselves, to brush their own teeth. So, we can, so they're just developing different, ways to kind of cope with something new being added on to what they already do or they already know how to do. And school is certainly a situation that we can think of that is always proposing new situations, especially as kids get older. We always want to see kids expressing themselves in spontaneous and creative ways. So watching children play is just one of the most fun, interesting things to do. Just watching kids, how they interact with each other, how they pull in make believe or they kind of imitate what they see with adults. But just that whole aspect of play and being silly and having fun and enjoying life, enjoying sometimes the small things in life that adults overlook is just such a nice, refreshing thing. So that is certainly something we want to see in a child. And then developing satisfying relationships with other kids and also with adults. We don't ever want to see a child just have a relationship with adults and not relate to their peers. That is not going to be very healthy for them, especially as they are going through school. So we want to see them having satisfying relationships. They've got friends, they have kids that they can play with and play happily with. And of course, we want to also see them be able to get along with and relate to adults and respect adults, but certainly we want really to see both. All right, so the causative factors, so biological factors when we do see some issues with kids, of course, we always have to look for genetics. But not everyone with a genetic predisposition is going to develop a mental disorder because we have to assume that things like resilience and intelligence and having a supportive, healthy, stable environment is going to help avoid the development of a mental disorder. Neurobiological, again, dramatic changes are occurring in the brain during childhood and adolescence. And and we have to think about the changes in the especially frontal and prefrontal cortex regions of the brain in the teenage years. So that leads to improvements in executive functioning, organizing, planning, and things like that. But earlier in adolescence, of course, typically we see kids that have a little bit lower emotional regulation, so they're not able to regulate their emotions. They may be very much all over the place with their emotions, very happy, very sad, dramatic, things like that. And they just don't tolerate frustration very well. But emotional and behavioral control, we usually see that increasing over the course of adolescence. I have actually read other articles that kind of describe adolescence as a period of normal psychosis. So that's how all over the place that adolescents can be as far as their emotional regulation and things like that. Okay, psychological factors. I'm on psychological factors next. So, temperament, I think I've mentioned that before, that we all have an inborn temperament. And of course, that can certainly impact a person's ability to cope and how they relate to stressors and how they express themselves emotionally. And that factor of resilience. So, on page 173, there's a very nice little paragraph that really details what we're thinking about when we think about resilience. And I think I mentioned this a little bit. I touched on it a bit, I believe, in way back in Learning Plan 1. So just to capsulize that again, so a resilient child is able to adapt to changes in the environment. They can form nurturing relationships with other adults when the parent is not available. They have that ability to distance themselves from emotional chaos. They have social intelligence. They can read people. They kind of are understanding about things, and they sometimes then they set goals for themselves, and they just really distance themselves from whatever is going on at home. They have good problem solving skills, and they can perceive a long-term future. So they can see themselves out of this situation that they're in right now, and they are able to see that they have goals. They're going to go to college, they're going to play an instrument, they're going to travel, whatever their goals are. So those are the characteristics of a resilient child. We always have to think about environmental factors. So, of course, extreme things would be witnessing violence and neglect and abuse. Bullying is also considered an environmental factor, and honestly, we could probably talk all day about bullying, but I won't. Maybe that's something that we could talk a little bit about in intermediate clinical in post-conference. That might be another, just a really good topic, because I would be willing to bet that we will be seeing patients that have had bullying happen to them either currently or in their past life. And even if somebody is an adult and they were bullied when they were a child or a teenager, oftentimes those scars kind of persist. So we can't just think, oh, they should be over it. I know adults that are still very deeply affected by the bullying that they experienced when they were children. And again, we literally could talk about this all day. The other thing I just want to throw in as far as another aspect of bullying that's kind of more, more of a technological aspect to it, I guess, or a more recent aspect would be just that cyberbullying is so prevalent. And I'm sure that you're aware of that. But back in the old days, before all this technology and social media and smartphones and everything, and computers, before computers even existed, yes, there was life back in those days when computers didn't exist. But if you had a bully at school, the kid could at least go home and be in their own home and in their own neighborhood, their own environment, and they could get away from the bully. Unless of course the bully happened to live in their neighborhood, but many times that didn't happen. The bully kind of lived somewhere else, and you could go home and just kind of be with your friends and be yourself, and you could get away from the bullying. But now with bullying through social media and online, you can get bullied 24/7. So you can never get away from it. So that's a huge thing that has impacted that whole aspect of bullying and how that deeply affects people's mental health. As for cultural factors, on page 175, your book has a little paragraph on considering culture, and they're talking about child psychiatric problems in developing countries. Um, the other aspect to cultural factors is that think about people that have come from other countries and they have parents that perhaps don't speak English and are just not really assimilated into the American culture. So they want to very much keep their own culture in this country. And the kids go to school, and it's really hard for the kids because when the kids are at school, they want to be American and they want to do what the American kids are doing. They want to fit in. And when they go home, they may have some expectations from their parents that are very different from American expectations. Perhaps they're expected that they're going to do some chores that maybe American kids don't have to do. And then they're not free to do after school activities, go out and play, join sports or anything like that. They can't do after school stuff because they've got a job to do, or perhaps they even have to help with, if they're older, they have to help with the family business. And perhaps other kids aren't doing that, and it really sets them apart and makes life very, very difficult. So having their foot in two different worlds. One foot is in in their home with all of those cultural expectations and rules, and then the other foot is in school and they want to be American, and sometimes that pull can be very, very difficult for them. Okay, little case study and discussion. Mimi, 13, is a child with many risk factors for the development of mental illness. She is the child of a single mother who suffers from post-traumatic stress disorder from growing up severely abused herself, and this has also made the mom agoraphobic. Mimi's mother is unemployable because of her emotional instability, and her mother does love her but often keeps her out of school to take care of her. So the child is taking care of the mom. Despite all this, she develops normally. You hear the term resilience used, and we just really talked about some characteristics of resilience. So perhaps that she's really able to distance herself and set some goals, has good social intelligence, and I would bet that she probably has made a pretty good relationship or rapport with some of her teachers and maybe even some neighbors. So she's getting some of the nurturing that she's missing from her mom. So, an audience response question. Mimi's mother is not abusive or neglectful, but she does put her child at some risk for being overly controlling and keeping her a bit too close, largely out of worry or fear. So, which of the following is the most prevalent form of child abuse? So I know we haven't really talked about child abuse yet, but this maybe will just get you thinking a little bit. There is another learning plan on domestic violence and child violence in childhood and with older adults. So we'll talk more about that in another learning plan. But I'm hoping that you're guessing that neglect is actually the most prevalent form of child abuse. So simply not meeting, it's not simple, but not meeting the child's needs. So whether it's physical needs, emotional, it could be just any number of needs. So, and that really is going to put the child at risk for what they call in the book ACE, which is adverse childhood events. So, and that is something that is certainly they're looking at correlating those adverse childhood events and the impact on the mental health of that child. And there's studies that are ongoing. Okay, so now we have to think about assessment. So assessment data, collecting the data, doing a mental status exam, and a developmental assessment, of course, is very important. Nice table to look at on the bottom of page 175. Types of assessment data. So, of course, the history of present illness. And that's something that you're probably familiar with med-surg concerns. So you take a history of presenting illness. What's the chief complaint and how long has it been going on? How did it progress? Have they sought help? Have they done anything about it yet? What is the effect on the child? And then also, of course, because we're thinking more psychosocial, the effect on the child's life at home and school and the effect of the problem on the family and the siblings' lives. So history of present illness, a developmental history. So pregnancy, birth, neonatal data, developmental milestones, play, social skills, friendships, all kinds of things there. Developmental assessment, so developmental history, and then a developmental assessment as to what are their psychomotor, language, cognitive skills, interpersonal social skills, academic achievement, and behavioral responses to stress, things like that. And then a neurological assessment. Of course, you would always want to look and see if they have any difficulties with their brain or sensory functioning and their reflexes. On page 176 at the top, there's also, we always want to look at their medical history to see if they have any medical issues going on, allergies, things like that, any medications that they're on, illnesses or injuries. Family history, of course, is huge. And then a whole mental status examination, general appearance, activity level, coordination, affect, speech, manner of relating to people, intellectual functions, thought processes and content, and characteristics of their play. So very similar to what we look at in adults, but of course, just a little bit more specific as to what we're looking for in children. So general intervention. So we do our assessment. We also have to think about some interventions. So we have behavioral interventions, play therapy, bibliotherapy, expressive arts, journaling, music therapy, family interventions, psychopharmacology, and disruptive behavior management. Okay, so that's an awful lot for one slide. But behavior interventions. Those are interventions that are designed to reward desired behavior and reduce maladaptive behavior. So most child and adolescent treatment settings use that type of a structured program. And, you know, some of those methods certainly can be used at home, and they're also many times used in the school systems. And so we're thinking about like privileges are awarded based on points that are recorded each day or numbers of stickers, you know, whatever, things like that. So play therapy, play is called the work of childhood is play. So play is really super important. And so sometimes through use of play therapy, it allows kids to really express their feelings through the natural use of play. It should come very naturally for children. It can help younger children kind of work through painful memories also. Bibliotherapy involves using literature to help the child express their feelings in a supportive environment, gain insight into their own feelings, learn new ways to cope, things like that. So when you read a story to a child, they unconsciously identify with a character, and the book says they experience a catharsis of feelings. So, in other words, they just really can feel a whole lot better related to the character in the book, and they see themselves as going through the same thing that the character is. And so they also can learn new coping mechanisms and skills from that book. Of course, whatever book you're reading should probably make sure that it really is developmentally appropriate, for that child. I can think of an example, the Berenstain Bears. I don't know if you've ever heard of those books, but they're really quite nice because they have so many different titles, and many of them really do relate to things that are just stressful for children in general. Couple of titles of this particular series. The Berenstain Bears in the Dark because they're afraid of the dark. The Berenstain Bears, No Girls Allowed. So they're having normal childhood issues of kind of the boys wanting to be by themselves and wanting to leave the girls out and maybe how the girl feels. The Berenstain Bears and the Bully. So there's one on bullying. Let's see. The Berenstain Bears learn about strangers. So all kinds of different ones, and there's a few others too. I'm just kind of looking this up online real quick. Moving Day, Bad Dreams, and I know there's others on like when the mom goes to work and the kids have to go to daycare, and the Berenstain Bears go to the dentist. There's a doctor. There's all kinds of things like that. A lot of those really truly relating to kind of like normal childhood fears and experiences, but the child really does feel comforted by a story and reading about the character and how the character deals with different types of situations. Expressive arts therapy. That's kind of a nice way for kids to express their feelings in a nonverbal way. Sometimes it's hard depending on the age of the child or maybe even the willingness of the child. They may have a hard time expressing themselves. So this gives them a nonverbal way to express themselves. Journaling. Now, again, journaling is good, but it depends on the child the same way it depends on the adult. Some adults love journaling and others really don't like it at all. They just feel like it makes them rehash things, makes them feel worse. So really truly depends on how the child or adolescent is going to, how they are going to respond to that. It might be, it's a good way for them if it does help them just to be able to like set goals, evaluate their progress, just kind of record their emotions. And then maybe when they read back, they can kind of understand themselves a little bit better. But again, I just have seen that kind of backfire and sometimes it makes people feel worse. So we really do have to be careful and see how the patient responds if we're trying to encourage them to do some journaling. Music therapy, healing power of music is certainly recognized for a long time. Again, I guess I would just say that we have to make sure that the music is appropriate and that it's not, going to cause further distress to the child or adolescent. Family interventions, we always need to be involving the family because a child really is very dependent on their family. A child really is not able to fend for themselves and, procure everything they need from the world for their own development and for their own life satisfaction. So they are very dependent on family. And so the family really needs some help too. So family counseling can be a huge component of treatment. Sometimes family members are even given homework to practice new skills, and then they can come back and talk about it with the therapist. So that really can be very, very helpful. Psychopharmacology. So sometimes, we do need that multidimensional approach, individual, family, group, medication. And usually you don't ever just want to give a child medication. You certainly would want to first, of course, as nurses, we want to make sure that it would be on a list of approved medications for that child's age, but also medication and therapy, combined with something else is usually the most effective. For disruptive behavior management, sometimes in spite of our best efforts, sometimes kids, especially if you're thinking about working with kids on an inpatient unit or adolescents, sometimes they do lose control of their behavior. And so we really have to make sure that everybody stays safe. So that's another incidence of teamwork and collaborating with other disciplines and safety. So think about lots of CUSIN principles there. So we really want to make sure that everyone stays safe, but we really should, especially with kids and adolescents, really use that concept of the least restrictive environment. We really don't want least restrictive intervention. We really don't want to be putting a child or adolescent into restraints as like the first thing we do. So we really need to learn to use lots of other different types of interventions, and truly seclusion, restraint, things like that that are very high level restrictive interventions really should be used as a very much of a last resort, and just as your book goes through and talks about, just really very we have to do those things really very very quickly. So get them in, get them out very, very quickly as soon as you possibly can. Those types of interventions can be really psychologically dangerous. Some things that are less restrictive would be things such as your book outlines very nicely on page 178, like having a timeout. So asking a child or adolescent to take a timeout, that's just kind of a great thing to help them to just self-reflect a little bit and encourages them to take control of their own behavior. So it really is not very restrictive at all. You just kind of, encourage them, and usually they go to a designated room or they sit on the periphery of the activity until they gain self-control. And then it's always helpful to kind of debrief with them and just to kind of ask them to, if they can, think about what happened and maybe ways that they could have avoided that happening and especially to avoid that happening in the future. A quiet room is another type of um, non-restrictive disruptive behavior management technique that we can use. So just having an unlocked room open for a child who needs an area with decreased stimulation, they can kind of go in that room when they want to. And your book suggests that it's like carpeted and supplied with soft objects. That would be really great. Maybe some music and maybe some yoga mats for some meditation or some yoga poses, things like that. But it just kind of helps the child to kind of compose themselves in an area where other people, like the other patients on the unit, can't really see them. But usually you do want to have the support of an available staff member. Okay, so this is just a little, I've got a couple of examples of some bibliotherapy that I found. So this book is called Bullies Are a Pain in the Brain. And so again, kids can read this book and maybe see themselves in the main character, and maybe even learn some techniques for coping with bullies. And this one also, No More Bullies. So this sounds like it's a fun activity book, puzzles, mazes, and word searches, plus lots of tips for standing up to bullies. It's great that we have these, but isn't it kind of a sad commentary on our society that we have to have books like this, that people are developing, books and fun activities related to bullying because it is just so very prevalent. But anyways, it is good that we have these resources that are available. So I just wanted to kind of give you another couple of ideas or examples of some bibliotherapy. I think these are called Emoda plush dolls. They're dolls for helping kids identify their emotions. And apparently the eyebrows and the mouth is kind of like movable. You can, because they're plush, you can kind of move the eyebrows up and down into different shapes, and the mouth also apparently goes into different shapes to kind of help the child, so the child can play with these dolls and kind of maybe express how they're feeling, but without necessarily talking about it verbally. Or the parent or caregiver the nurse could also kind of put the doll's face into a different type of an emotional state and maybe ask the child if that's how they're feeling right now. So it's just basically helping kids identify emotions. So really, it's kind of nice that there are a lot of resources out there for kids. Advanced practice interventions, certainly group therapy. Younger children, again, use play and ideas more. Grade school children combines play, learning skills, and talk. And adolescents really can work more at identifying their emotions, modifying their responses, learning skills, talking. They're going to be more insight oriented at this age than the younger ages. And they're really focusing a lot on peer relationships and addressing specific problems that they're going through. And then cognitive behavior therapy, replacing those negative self defeating thoughts with more realistic and accurate appraisals to help their functioning. Okay, so we're going to be looking at some neurodevelopmental disorders. So, communication, motor disorders, specific learning disorder, intellectual development, autism spectrum disorders, and attention deficit, which is ADHD, attention deficit hyperactivity disorder, ADHD, or ADD, which is attention deficit disorder, and that is without the hyperactivity. So, as for motor disorders, we're just going to talk very quickly. Just one slide on tic disorders. Tourette's disorder, of course, is the most common one. There's something else called persistent motor or vocal tic disorder, and that is something that goes on for more than a year, and provisional tic disorder, which is something that occurs less than a year. So, Tourette's disorder has motor tics, multiple motor tics, and at least one vocal tic for more than a year before these kids are diagnosed. And all of these problems occur before age 18. Typical age of onset, 4 to 6 years old. And the symptoms kind of peak in early adolescence and they diminish into adulthood. Your book talks about Hollywood and how they characterize people with Tourette's disorder, and usually they characterize that aspect of having a foul mouth. So it's called coprolalia. So that's uttering of obscenities, and that's actually happens in about fewer than 10% of cases. So more than 90% don't do that. But of course, you know how Hollywood is. They always have to put probably the most negative spin on things. And truly, Hollywood can either influence us to the positive or to the negative, as you're finding out with your movie assignments, as far as how the general public is going to think of a particular illness. What's really difficult about Tourette's disorder is that these kids have low self-esteem because they feel very ashamed, they can't control their symptoms, they feel very self-conscious, and they are rejected by their peers, and they may even be, of course, bullied and made fun of by their peers, and they kind of tend to limit going out in public because of the fear of displaying their tics. Again, the tics are not in their conscious control. They have a great deal of difficulty with those tics. And the tics are really quite variable. There was somebody that I took care of many, many years ago, and he had some obsessive compulsive kind of components along with his Tourette's. But for him, the compulsion of he had this desire to like pull out all of his teeth, and the compulsion was stronger than the pain that he felt with pulling out his teeth. So he actually really felt like he had to follow through with pulling out his teeth, and he did that with a pair of pliers, and he pulled out all his teeth in somewhere in his 20s, and so he had no teeth left. And then he kind of had this spitting behavior, so he didn't have any teeth left, but then he had this compulsive behavior of spitting, and he would spit everywhere on the unit. So he really was a challenge to take care of. He would drink milk especially, and then just kind of develop a lot of saliva, and then be spitting in public waste baskets, and spitting on the floor, and spitting in his room, and spitting in public areas where people were sitting. Very, very difficult behaviors. There were some times where he would just get up on top of the dining room table and start, moving around in various ways. So, but not everybody is that extreme. And maybe some of you know people with this type of a tic disorder. So it really can be variable, but most of the time people really do feel very self-conscious, and kind of decrease their own socialization because of the tics. So there is a familial tendency. About 90% of cases, there's a family pattern. And again, it does, think about comorbidities. We always have to think about those. Depression, obsessive compulsive disorder, and ADHD. So sometimes there can be a little bit of, all of those components in the same person. Behavioral techniques can really be very helpful with treating tic disorders. Your book kind of describes that there's a specific type of behavioral intervention, CBITS. Oh my goodness. But it helps, you don't have to memorize that. It works by helping the patient become aware of the building up of that urge to have the tic, and then using a muscular response in competition or that's incompatible with the tic. Wow, so that's pretty interesting behavior techniques. Medications. So there's a couple of medications that are approved. Haldol is the one I'm most familiar with. I guess I've seen that more often over the years in treating people with Tourette's disorder. Orap is another one, and Abilify can also be very helpful. Clonidine can be helpful. So clonidine is a really interesting medication because it was originally discovered as a blood pressure medication, but it does help with this disorder. It helps with Tourette's. It also helps with people that are going through opiate detox, and it can also help with people that have attention deficit disorder. So it really is quite an interesting. Oh, and also, wait, I'm forgetting one. I believe that I've seen it used on 1K with people that have post-traumatic stress disorder, and they sometimes get this at night to help to decrease nightmares. So what an interesting drug and how many different things that it is being used for. Klonopin, which is clonazepam, an anti-anxiety drug, can also be helpful. Oh, and it looks like Botox. I have never heard of that being used. That must be a newer development. That can help to calm down the muscles. And then deep brain stimulation is kind of like a sort of a pacemaker for the brain. So, and again, we kind of talked about deep brain stimulation for depression also. So sometimes by targeting particular areas of the brain, then those symptoms of the tics can be decreased. So, intellectual development disorders. So, people with these disorders have deficits in their intellectual functioning, social functioning, and daily functioning, really meaning activities of daily living. In a nutshell, they have deficits and problems with reasoning, problem solving, planning, judgment, abstract thinking, academic ability, impaired communication, language, reading social cues from other people, and regulating their emotions. And again, their ADLs as far as age appropriate activities of daily living, whether at work, school, and performing self-care types of activities. So we're seeing this usually early in childhood and can range from mild to severe. Everything is on a kind of on a spectrum and also on a continuum, as we kind of have been talking about since Learning Plan 1. So we do have to think about how dependent is the person on others for self-care. That's one of the ways to kind of determine how difficult their intellectual developmental disorder is. So application of the nursing process, when we're looking at kids, we're always going to be assessing for delays. So again, that Denver developmental test that I believe you did in health promotion is definitely something to look at. So on the bottom of page 180, there's a nice little table, assessment guidelines. So again, it just is talking about looking for those delays, looking for if they are achieving any milestones, and if we are, oops, I accidentally hit fast forward, and if I hit backwards, the whole thing is going to, I would have to start this whole thing all over again. So I'm just going to continue what I was talking about. So we're looking for assessing for areas of independent functioning, which is very important. We absolutely need to be looking for areas of that could signal possibilities of neglect or abuse. So sometimes developmental or behavioral problems, those kids are at risk for being abused. So we really have to pay very careful attention to that. Nursing diagnoses on the top of page 181, there's a nice purple table, and it talks about signs and symptoms of nursing diagnoses. Okay, I think it's time for me to take a timeout. I think what I'm doing, I'm realizing that I just flipped back one slide apparently. But I think what I'm going to do is I'm going to end um, this part of the recording, and I'm going to start over with a new recording, and I'm going to start with this slide, slide number 16. So if you want, you can just listen to this recording up until slide 15, and then I'm going to start a new one starting with this slide. So sorry about that, but I guess my hand just kind of hit the mouse just a little bit the wrong way, and it kind of flipped the slide. And again, if I were to go try to like go ahead or change a little bit sometimes, that it just really messes up my entire recording. So I will see you on slide number 16.